My name is Eric Barsatan, and I'm the manager for Physician Relations and Medical Staff Services here at the Queens Medical Center, West Oahu. By the way, here at Queens West, today we are celebrating our 7th year anniversary in serving and providing care for the people of the West and Central Oahu community. So today, it's a big day for all of us. Today, speaking of health, the topic is kidney stones and you, from treatment to prevention. Right now, and throughout the presentation, if you could ask all of you viewers to be on mute. If you have any questions, please type your questions in the chat box and Dr. Andrew Sun will answer them at the end of his presentation. We know that this is a very important topic for many of you, so again, please don't hesitate to type your questions in the chat box. At this time, I am honored and privileged to introduce our speaker. Dr. Andrew Sun is a board-eligible urologist at the Queens Medical Center, West Oahu. He's trained in andrology, endourology, urologic oncology, robotic surgery, and reconstructive surgery. Dr. Sun is ready to provide compassionate and high-quality care to patients suffering from a wide range of urologic diseases. He received his Doctor of Medicine at the Keck School of Medicine at University of Southern California and did his urology residency at Stanford Hospital and Clinics. Dr. Sun's hobbies include hiking, swimming, and yoga. He enjoys spending time with his wife, 2 daughters, and 3 pug dogs. So Dr. Andrew Sun is on your screen, and all of you should be able to see him and his PowerPoint presentation. So welcome, Doctor. You may now proceed with your presentation.
All right. Thank you very much for that introduction. My name is Andrew Sun. As Eric said, I'm one of the urologists here at Queens West, and so I'll share my presentation. All right, so today's presentation is about kidney stones in you, and everybody can see it? Someone give me a thumbs up? Okay, perfect. Okay, so I'm going to go over a few different things, kind of start out with some kind of basics about kidney stones, then get into some of the common questions, like why do you get a stone? What are the symptoms? How do we diagnose stones? When do they need to be treated? How do we treat them? And then the big one that I really want to focus on is how to prevent them. And then there are a few other kind of frequently asked questions that I'll kind of get to as well. So kidney stones are a very common problem. About 1 in 10 people will experience them during their life, and they're actually becoming more common. There was about a 70% increase in their incidence over the last 20 years. So it is a big problem. And the other thing is that once you have one, about 50% of the people who get a stone will have another one within the next 10 years. So it is a recurring problem. It is associated with being overweight, high blood pressure, and diabetes, though there are a lot of things that go into specifically why people get stones. But I can tell you, if you do things that kind of prevent these conditions, you also are probably going to be doing things that will help prevent stones in the future. In Hawaii specifically, dehydration, probably related to the warmer climate and the humidity, along with dietary factors such as kind of a high salt, high meat intake, are going to be associated with stone formation. So it does really seem like in Hawaii, we do see a lot of stones. And just kind of across the United States in general, kidney stones, including their treatment, diagnosis, and lost productivity to workers, because it's really painful if you have one of these, comes out to about 5.3 billion a year. So definitely a big issue. So first off, what are the kidneys, and what does the whole urinary system look like? And so the urinary system is really kind of composed of, broadly speaking, 4 different parts. You have the kidneys up top. Most people have 1 on each side, and that's kind of the production site for the urine. And then the urinal gets collected kind of in a drainage system. You can kind of almost think it like this street system for the sewers into the ureters, which are kind of the main pipes that take the urine down that was made in the kidneys down to the bladder. And the bladder's function is really to kind of store the urine, and then, when it's an appropriate time, urine gets excreted out the urethra. And the reason why it's important, in addition to just kind of making your urine, is that the kidneys really kind of regulate the levels of electrolytes, things like sodium and potassium in your body. They really kind of filter the blood of some of kind of the metabolic waste products like nitrates and something called creatinine, which is made by muscle activity. And then there also are kind of some hormones that the kidneys are important for making, including kind of stimulating your bone marrow to make red blood cells and playing an important role with your parathyroids in regulating your calcium levels in the blood. So what is a stone? So kidney stones, broadly speaking, are crystals. They're not like nice looking crystals. They actually look kind of ugly. So some people talk about making jewelry out of it. It does not look good on a necklace. But it's a crystal of solid material in the urinary system. And the vast majority of stones are going to be either calcium or uric acid based. And these crystals form when there's an imbalance in the concentration of the compounds in the urine. So you know how if you like have some like ocean water, like in a glass or in something, as the water evaporates, you see like the salt crystals come out? It's kind of like a similar situation that happens in your urinary system. So if you don't hydrate well enough and the urine can be too concentrated, you can see some of these crystals start to form kind of inside of you. And once you have one area of crystal that kind of forms, just more grows on top of it. And yeah, some examples of these crystals, calcium oxalate is probably far and away the most common in the United States. It's still the most common in Hawaii, but uric acid is probably more common here than just 5 to 10%. I don't think there's been a study on it, but in Hawaii, I'd wager this is like 20 to 30% at least. Some of the less common stones, calcium phosphate, kind of a subtype of calcium type stones. Struvite stones are associated with kind of recurrent urinary tract infections. We do see those here from time to time. Cystine stones are really rare. Those are stones that like form in childhood and are associated with some inherited metabolic disorders. That's actually not too common here in Hawaii. So why do people get stones? And I'll probably say this a few different times, but low urine volume, usually related to dehydration, is far and away the most important factor. So just like, if the urine's really concentrated and, you don't have very much volume to it, it's really easy for these crystals to form. And what you really should be aiming for is making around 2 to 3 liters of urine a day. And for most people, that means you need to be taking in about 3 liters of water, which is about 2/3 of a gallon. That's kind of hard to do. I don't always do that, but if you have stones, you probably should. The ways you can know if you're hydrating well enough would be kind of to look for dark or concentrated urine. That's probably the most obvious one. And also the other thing is if you're only urinating like every 6 hours or even every 4 hours, you probably should be hydrating a little better because it usually means your urine production isn't going to be very high. And like I said, your goal should be to drink around 3 liters, 100 ounces a day for most people. Although if you have like some heart conditions that you have to actually fluid restrict for, then that's obviously a different consideration. Diet is another big factor into why people get stones. So too much meat, whether it's steak, chicken, or fish, all can kind of lead to acidic urine. So a lot of people, or in the past, it's been thought that it's just the red meat that puts you at risk. It's actually all meat can put you at risk for stones. Too much salt can lead to more calcium in the urine, actually, through some of the transporters of ions in the kidneys. So really having too much salt in the diet is a problem. And, just between those two factors, specific, like you like your lau lau, it has both meat and it has a lot of salt. You like shoyu or poke, meat and salt. And then too much oxalate. Usually that's not the primary problem for most people, but there are some certain foods that are high in oxalate that I'll get into later that can increase the risk of stones. But usually, unless you're doing something very specific with your diet, oxalate's usually not the main problem. Another common kind of misconception is the role of calcium. So some people will go like really restrictive on calcium in the diet after they find out they have stones. You actually want to have what's a normal calcium intake, which is roughly 2 grams a day for most people. Because if you have too little calcium, you can get it increases the risk of stones. And if you have too much calcium, which is like you're eating basically like comes like their candy, that can also increase the risk of stones. So normal amount of calcium should be the goal. There also are kind of some medical conditions which can increase the risk of stones. By and large, bowel problems, and probably the most common one of these in Hawaii is gastric bypass. So gastric bypass patients definitely have an increased rate of stones. And it's actually, that one is due to the oxalate. So the way that that works, so if you have a gastric bypass and you have stones, what happens is generally related to the bypass, you're not absorbing as much of the fat in your diet. And that fat actually binds to calcium that you take in through the diet and prevents absorption. Now, the reason why that's a problem is that calcium in your diet actually binds to oxalate, which is the second half of a calcium oxalate crystal, and helps, and if it binds it while it's still in your intestines and inside your kind of like GI tract, it prevents you from absorbing it. So if the calcium has already been bound by the fat, it can't bind the oxalate, and you end up absorbing a ton of the oxalate in your food, and that puts you at risk for forming stones. Other things, Crohn's disease can have a similar problem, and then diarrhea, it's actually, if you have like chronic diarrhea or you use a lot of laxatives that make you have diarrhea, that actually leads to dehydration in a lot of folks, and that can also increase the risk of stones. Obesity in general is associated with acidic urine, which increases the risk of most stones. And then there are some kind of other issues with the parathyroid glands, or in some cases, poor kidney function that can kind of mess with the amount of calcium in the urine, and that can also increase the risk of stones. Specific to supplements, some people do mega doses of vitamin C. If you do a ton of vitamin C, there actually is a large amount of oxalate that gets converted to and absorbed, so that increases the risk of stones. And then if you are one of these people who, you're taking tons of calcium, and it oftentimes is like people eat Tums like they're candy almost, and you're taking way more than 2 grams a day, that you can actually have too much calcium in the diet and increase the risk of stones. So what are the symptoms of stones? So the big one, most famous one, is pain. And this is going to be like a sharp, almost cramp-like pain on your back and your side. It's usually just on one side, because usually, sometimes you can get stones that pass on both sides at the same time, but usually it's just on one side. And it will tend to kind of almost wrap around from your back into like the lower abdomen and groin on that side. In men, in some cases, as the stone moves down, you actually can have like the pain radiate into the base of the penis or even the scrotum. And in women, it can kind of radiate almost to like the vagina. The pain can be pretty intense. Some women will say that it is worse than childbirth. And it tends to like come in waves. Like you'll have an extremely intense like sensation of pain, and you'll kind of like wane to just being uncomfortable, and then it will come back at really strong, like really bad pain. Feeling sick to your stomach, throwing up, also another common symptom from the stones. And from urination, people will describe a variety of complaints related to urination. That's usually when the stone's close to the bladder, but typically you'll get this like kind of maybe some frequent and intense urge to urinate as it's getting close to passing. And you can often see dark or bloody urine. And as it gets down there, an uncomfortable sensation at the tip of the penis or even the clitoris is possible. Sorry, going back here one more time. So in the figure on the right-hand side, I crossed out fever, and mainly because that's, if you're just kind of having these other symptoms, like you're having pain, you're throwing up, you're not feeling well, you're having some blood in the urine, your back hurts, those things, sometimes if the stone's small enough, you can make it through those things and pass it. But if you start having a fever, that's a much bigger problem. So that gets me to kind of the next thing, emergency symptoms. So if you think you're passing a stone and you're having fevers or chills, you need to go to the hospital. That can be a sign of a very severe infection that can get very bad very fast. If you just generally feel like you have a horrible flu, like, when you you're sick with a bad cold or something, you just like, your body aches, you just kind of feel generally miserable. It's not like one specific thing. You should really just kind of get checked out in that case. Another one is if you notice suddenly, even though you're hydrating really well, trying to pass this stone, you're not really making much urine, or you just aren't making any urine at all. That's another reason you should go to the hospital. And if you get to a point where the pain is just too severe or extreme for you to do this at home, or you're vomiting so much that you can't keep anything down and you're getting dehydrated, that's another reason to go to the hospital. And this figure here kind of gets it like the infection. So if you're having fever and chills, you can literally just kind of have your kidney start to fill with a bunch of pus, more or less, and that can make you extremely sick. So when we place what's called a stent, which is a small plastic tube that kind of decompresses the kidney, you will literally see this stuff kind of pour out almost like it's toothpaste. And if you don't get that stent placed or you don't decompress it, you can get very sick very fast. Some people have kind of chronic stones, it may be associated with infections. It may just, for one reason or another, they just don't have that many or that severe of symptoms from it. But what that can kind of look like is, if you're having recurrent urinary tract infections, you kind of have this nagging back pain. It's, not bad enough on any individual day to take you to the hospital, but it just kind of keeps coming back. Or unexplained fevers. Those things can be a sign of chronic stones. And if you are concerned, it's not a bad idea to get it checked out. Because some people will kind of go for years and years just kind of with these symptoms until, they have a really bad episode that usually from an infection that will lead them to the hospital. And in those people, sometimes we find things like this, where this was a Queens West patient, where their whole kidney was basically filled with stone and pus. And, it was actually kind of past the point of no return. So we took them over to Punchbowl and took out the kidney. And when we, look inside to cut it open, you just see kind of all these big yellow, brown stones just kind of filling up the whole thing. The other thing that I would say is that sometimes there aren't any symptoms from a stone. Most of the time when there's no symptoms, usually, it's not too bad, but just know that just because you don't have symptoms doesn't necessarily mean that you don't have a stone that could cause a problem. So how do we find these stones and how are they diagnosed? So imaging these days is really kind of key to confirming you actually have a stone or not. A lot of the symptoms I mentioned, there's a lot of different things that can cause those. There's a lot of different causes of back pain. So you really kind of need some kind of imaging to figure out if you have a stone or not. And these days, a CT scan is kind of usually the gold standard for diagnosis. The downside of the CT is that it has the highest radiation exposure, so you don't really want to be getting these all the time. However, they kind of is the only reliable way to see the ureter all the way down, and it's the most common thing. So if you show up to the ER with flank pain or back pain, there's a very high chance they're just going to get a CT and see. And I'll say typically we want to have one of these before we take you to surgery because it gives us a really good idea of where your stone is, how much stone there is, and that really helps us kind of plan the operation. The picture on the right side of your screen, that's just an example of like a CT scan. So that kind of area where it says like 16.5, those bright white things, those are the stones that appear very bright on the CT, and that kind of light gray thing around it, that's the kidney. Now, there are other ways we can look at stones. So ultrasound is one of those, and it looks for something called hydronephrosis, or usually we'll term it swelling in the kidney or fluid backup into the kidney. And it's really good for looking at like any large problems, like if there's a blockage, there's usually this hydronephrosis or swelling, and it will see large stones. Ultrasound is not super great for looking at small stones. So like the picture I put on the right there, that could be a stone, that could be an artifact in the kidney, that could be a small calcification that you can't really get out anyway. So it's not really a great thing for like planning the operation, but it can show if there's a big problem. The main benefit of it is there's no radiation associated with this. It's just an ultrasound wave. And then I'll often use these kind of as in the outpatient setting first to see if there is anything that I would want to go ahead and get a CT scan for. In the past, we used to just kind of use plain x-rays to look for stones. There aren't too many people doing that like off the bat. Like if you're having symptoms, there's not too many people who are going to order just an x-ray because it usually isn't quite enough information to see if you need to operate. Like, so for example, this is just a picture of an x-ray. That shows a calcification that's overlying where the kidneys live. Your colon also overlies that. Some people, the gallbladder could hang down that low on that side. You don't really know. So you can use it in follow-up settings. So like, if someone doesn't like ultrasound, they may order x-rays as a follow-up imaging test for stones. In that setting, it's usually okay, but kind of as a primary diagnosis, like you think you have a stone that's causing a problem, it's usually not what we order these days. So big question is, when do stones need treatment? And location is really kind of the big key in this one. So stones that are in the ureter, so you see that pipe that kind of connects the vein-shaped thing down to the kind of triangular bladder shaped thing at the bottom. Stones in the ureter tend to need treatment. The vast majority of them cause symptoms. Usually when a stone's in the ureter, that's when you get these really intense back pain. That's when you're throwing up. That's when you're showing up at the emergency room. And if you do get one there, it either needs to get treated, or if we're going to try to pass it, we do need to do something to confirm that it passed. Now, if the stone is just hanging out up in the kidney, up at the top, sometimes it will cause symptoms, but oftentimes people will just have these and they may never cause a problem. So just because you have a stone up in the kidney doesn't necessarily mean it needs to be treated. So there's usually at least an option of observation if there's a stone up in the kidney, but there are definitely some exceptions to that as well. So when do stones need treatment? Size plays an important role. So in general, anything bigger than a centimeter, we're probably going to be talking about taking it out in one way or another. And if it's in the ureter, the size really correlates with how likely you are to pass this stone on your own. So this is a more updated diagram than kind of the rule of thumb we were taught. But in general, I would say stones under 5 millimeters. If you can kind of get the pain under control, you can get the nausea under control, most of the time it's worth trying to pass that on your own so you can try to avoid surgery. Obviously, if it's just really, really bad, or you have to get back to work or something and you just want it done, there are reasons why we take people to the operating room for those. But if you have less than 5 millimeters and under, usually you should try to pass it. 5 to 7, some people may say 5 to 10 millimeters. Those people, you can give it a go, but just be prepared that you may or may not be able to pass that. In general, when stones get to be 7, 8, 9 millimeters, the chances of passage are not really in your favor. So if you show up to the ER with that kind of stone, I often will kind of at least not be a little more, be like, yeah, if you really just want to get this over with, we can just admit you and operate on this now. So size of the stone really kind of plays a big role. The other thing that was in this graph that kind of plays a role is that what third the ureter is in. So if you're like right at the top in the upper ureter, you have a lot longer to go and a lot higher chance of failure versus if you've already made it to the mid ureter or the lower ureter. The other things to know about chances of passing the stone if you get one. If you have had stone, like say you've had surgery before for a stone, you've had a stent before, or you've passed stone successfully, if you have any of those things, usually the ureter is dilated a little bit, so your chance of passage actually is a little better than just kind of a run-of-the-mill person. So that always is something that I take into consideration when I see patients with this. As far as needing treatment, symptoms, yes, if you have just kind of uncontrolled pain or vomiting, we'll usually think about treating it. And kind of really, if you're showing up to the ER more than once, then it usually means things are not going super well at home. And usually, if you're that second trip to the ER, I'll usually kind of recommend we do something different. If we're just kind of talking about, like your symptom, like you're just having these symptoms, you're otherwise feeling okay, the goal of treatment is to get rid of the stone. So usually, and we'll talk about how we do that, but the goal is usually to actually treat the stones in those settings. Now, treatment also can mean that we just have to put up a stent and get you better from whatever is going on before we actually go after the stone. So if you have an infection, and again, that's the fevers, chills, generalized feeling unwell, you show up to the ER, white blood cell count's very high, the urine looks very infected, the CT scan can have some kind of signs of inflammation as well. If we think you have an infection, you need antibiotics and you need a stent placed, but we're usually not going to be talking about going after the stone. And really, again, if you have that going on, there is a risk of getting sepsis, which is basically a systemic infection that can progress very rapidly if it's not treated. The other situation we see not uncommonly is that if the stone is causing so much of an issue that it's like impairing your kidney function, and this is really what that drop in urine output gets at. So if you're not making very much urine, and it may very well mean you're having some significant kidney injury going on. And that's something they'll measure at the emergency room. You really, and those people usually just want to stent them too, because there usually will be some kind of significant electrolyte problems. Potassium is probably the one we pay the most attention to that can have a pretty severe effect on the heart if it gets really out of whack. So usually in these situations, it's kind of an emergency. And the stone, we will have to treat at some point, but usually we're just trying to get you out of trouble first. As far as ultrasound, yes, I will get to that, but we still do that. But yes, these situations are emergent, and really, you know, we gotta just get the stent up. And yeah, a second procedure usually for the stone itself is needed. There are some situations where if we can't get the stent up from below, so say you have like a really nasty stone or you have multiple stones that are trying to pass and we just can't get access from below, then rarely we have to have the interventional radiology team place a tube through the back to decompress the kidney. But again, if any of these situations occur, either the infection or the severe impairment in kidney function occur, you really need to get decompressed. A big thing I also kind of want to hammer home is that kidney stone stents are really any device that is placed in your urinary tract, though all of those are temporary. I mean, I guess there are a few exceptions, but by and large, just anything placed in your urinary tract is temporary. So if you ignore your stent for like years, that can cause a huge problem. So just know that if you do have one of these situations occur where a stent is placed for an infection or poor kidney function, you do need to come back and follow up with us because that stent cannot stay there forever. So how are stones treated? First one, it's not so much a treatment, but you know, if you want to try to pass the stone on your own, what that's called is medical expulsive therapy. Really what you're going to want to do is you're just going to try to hydrate as well as possible. You're going to want to try to be making as much urine as you can to really flush that stone down. And typically, you know, if you see a doctor, you see the emergency room, you'll be given a strainer. And you want to try to strain your urine and collect as many stones you can. Because usually if you're able to collect the stone, when you do see us, we'll send it off to the lab for an analysis, and that helps us prevent it in the future. While you're doing this, we try to control your symptoms with medication. So there's typically some medications given for pain. There are some medications given to help with any like nausea or feeling sick to your stomach that you have. And then we'll oftentimes prescribe a medication called tamsulosin, which is also known as Flomax, that it's controversial. Some studies say it helps pass the stone, some studies say it doesn't, but both of them seem to suggest it may actually help with symptoms. So that's another one we'll usually give you. And if you are going to do this, usually we need to see you in, you know, anywhere from 4 to 6 weeks after to see if you actually passed it or not. Now, this is getting to the ultrasound. Yeah, so external shockwave lithotripsy, also known as ESWL or ESWL, that is where they can use ultrasound to try to break up the stones. It still requires you to go to sleep under anesthesia because it's, you know, if you try to be awake for this, that'd still be really painful. And also they need you to hold really still so they can target the stones. Usually you're able to go home the same day. It's generally a safe procedure, but there are some kind of rare and serious side effects that can happen because basically you're delivering a pretty tremendous amount of energy to one of your internal organs. And there are some things that can happen with that. In general, this isn't used as much today, mainly because there are a lot of limitations on stone size and stone type where you're not supposed to do this. And then also, if you were going to use it on like every stone, you're going to have to stent most of those people, which is really the only advantage it has over some of the like ureteroscopy. So if I'm honest with you, actually on the mainland where I trained, we weren't doing this very often. And actually at Stanford specifically, they didn't even have access to this because in general, it was felt to be an inferior technique to ureteroscopy. But it is still something we do, and there are still, you know, some stones that it makes sense to do it in, and it's something we at least talk about. So ureteroscopy is basically what we probably do for the vast majority of stones these days. So what this involves is using a very small scope to access the kidney or the ureter, and through this tiny, tiny scope, you can pass this little laser fiber and a basket to kind of both break up and then remove any pieces of stones. It has a better stone free rate than shockwave lithotripsy, but most of the time you are going to have a stent after this procedure to kind of help keep the ureter open while you recover from the operation. In general, this is a safe procedure, but it definitely requires anesthesia, but you do get to go home the same day. There really aren't that many limitations on what stones this works for. This is pretty effective for pretty much every stone. There are some size considerations we'll take into account, but the lasers are getting better and better with each generation. So even some huge stones, we've actually had some really good success treating with with this technique. Now, getting to those huge stones, percutaneous nephrolithotomy, also known as PCNL, that's probably the procedure we do for these really huge stones, or things called like a quote unquote staghorn stone. And it's probably the gold standard for all the stones greater than 2 centimeters. However, this is a much larger operation than kind of any of the other things we do to treat stones. And what this usually involves is there's an incision through your back, and then there is either the interventional radiology team does it, or sometimes we do it ourselves. We'll basically place a tube from that incision all the way through your kidney into the inside of the kidney, and use that to place a very large scope in and break up the stones using a variety of devices, and then take out all the pieces. Very effective for these large stones, but that is a real operation. Most of the time, you're going to need to be admitted to the hospital for usually 1 to 3 days after this, depending on how things go. And you'll usually can expect to have a tube out the back and possibly even a stent after the procedure. There are some places on the mainland which are trying to do some of these for certain patients as an outpatient, and I've seen a few of those procedures go well. But even on the mainland, where I was, most of the folks were still getting admitted to the hospital after this procedure. So once you get your stones treated, the big question is, how do I ever keep this from happening again? And there are a few things in the labs we really, really use to guide and personalize prevention. And number one is the stone analysis. So usually whatever you get done, there usually will be some fragments collected in some way that get sent off to the lab. And based on what kind of stone you have, that kind of helps give you some general recommendations. For each patient specifically, there are things you can do. You can do a 24-hour urine collection. You also want to test the urine pH, and there also are some blood tests that we do to try to help figure out if there's anything specific to you, either in your diet or with medication, or the blood test. Sometimes people have these rare parathyroid abnormalities that need to be addressed. On the right side of your screen, that's basically an example of, this is LithoLink. We actually don't send too much to them. We just do it through DLS. But basically, the big things we look at in your urine for this 24-hour urine collection is the amount of urine that you made, how much calcium was there, how much sodium was there, and how much citrate was there, and a number of different values that kind of help us figure out why you're at risk for stones. And so get on to prevention. Yeah, hydration is number one. So again, the goal is drinking about 3 liters a day. That's about 2/3 of a gallon. And obviously you don't want that to all be like juice or high calorie soda. So low calorie or no calorie drinks are recommended. It doesn't necessarily have to be water, but water is probably the most available drink that fits those categories. In particular, things like Diet Coke or Coke, are some phosphates in them that can actually increase the risk of some stones. So we don't usually recommend drinking too much of those. Coffee is generally okay, but it does have a small to moderate amount of oxalate in it, so you don't want to just be having coffee all the time. The other thing people ask about, which is kind of, I think, related to that, is caffeine. Caffeine in and of itself usually is not going to cause you to have stone problems. If you drink a ton of caffeine, you may have some like overactive bladder symptoms, which may have some overlap with some of the stone things, but usually caffeine won't cause a problem. And there's also not really a specific restriction on alcohol. Alcohol typically doesn't cause stone formation. There was actually, I think, one study, I think it was like Germany, where they actually found beer may decrease the risk of stones because it actually forces it's a diuretic, so it makes you make more urine. But we don't typically recommend, drinking a lot to prevent stones. But it probably doesn't increase the risk. Other things you can do are definitely with the diet. So reducing salt in the diet, which is a huge challenge, can really help. When you have salt in the diet, what it does is it actually increases the amount of calcium in your urine through the transporters, ion transporters in the kidney. And then for people who have cystine stones, it also increases the amount of cystine. So really, to reduce salt in the diet, you're going to you need to avoid cheese. Frozen or processed foods tend to have a lot of salt. Meat tends to come with a lot of salt based on how it's seasoned. Canned products, baked goods, chips, pickles, olives, condiments, everything that makes things taste good, all of that probably has salt. So it's not that you can't have it, it's just that if you do have stones, it's really going to be something you want to try to limit, or at least take in a reasonable amount in the diet. Fruits and vegetables are, they're good for a number of reasons, but For our purposes, they tend to have, that's where your citrate comes from. And citrate is something that if it ends up in your urine does help prevent stones from forming. But yeah, 5 servings a day of fruits and vegetables is a good thing. Oxalate's a tricky one. And like I kind of said earlier, it's usually not the primary problem for most people, but there are specific populations where it does matter. Or if you're kind of doing things with a diet, like someone here recently, he was drinking 3 spinach smoothies a day. And that actually probably was the reason why he had stones. But things, there's a long list of oxalate containing foods. It's easiest probably just to Google it and, read through and see if there's anything that resonates with you. But in general, things like beets, sweet potatoes, spinach, and actually I had to look this up, but taro actually has quite a bit of oxalate. Chocolate has a fair amount of oxalate. Most nuts, in particular almonds, and then soybeans also are very rich in oxalate. So these things, if you have them in excess in your diet, can independently increase your risk of stones. And then that picture on the right side, that is, kind of roughly what you're supposed to be doing, like a little bit of meat, mostly vegetables and fruits. And then the other kind of nice thing about that it shows is that fluid intake, 3 liters a day. And this is an old urology adage, but yeah, if you put like lemon or lime in your water and you do that every day, that does give you some citrate, which may help prevent the stones. Also going on to the diet, eat less meat. So meat in general, the intake will lead to acidic urine. Also, it's associated with gout, which is a common problem here as well. Meat, kind of like I said earlier, it's not just red meat. It's really anything with eyes is kind of probably the best way to put it. So whether it's steak, chicken, or fish, all of this can lead to acidic urine and has a uric acid in it. So it's not that you can't have it, but instead of like having it 3 meals a day, maybe 1 or 2 meals a day is probably the easiest way to put it. But that is a big role for some people here. And kind of like I also said earlier, you want to just have a normal amount of calcium. You don't want to exclude calcium from your diet. So around 2 grams a day is pretty much a good number for most people. Postmenopausal women may need a little bit more. But in general, if you have too little salt or if you have too much salt, that can increase the risk of stones. And yeah, just general recommendation, 3 servings of calcium-rich food a day with meals. There are also some medications that, based on lab results and what kind of stones you have, we may do to help prevent you from getting stones in the future. Broadly speaking, there's a medication class called thiazide diuretics. The most common one used here is hydrochlorothiazide, or HCTZ. And that actually works best if you've already reduced the amount of salt in your diet, but it actually reduces the amount of calcium that makes its way into your urine by adjusting how the ion transporters in your kidney work. So that's a common one that we'll use. Potassium citrate is another one we'll use. It's good for almost every kind of stone. It makes your urine less acidic, and it also puts citrate into the urine. And the citrate will help prevent crystals of like calcium oxalate from forming. So it really, that's actually probably the most common one I start people on. If for some reason your potassium levels are high or you're on medications that prohibit the use of potassium, then we can use other things like sodium bicarbonate, which is literally baking soda, sodium citrate, and for some people, calcium citrate are other things that I'll use as well. Allopurinol, which is a common medication used for gout to kind of lower the amount of uric acid in the blood. It also lowers the amount of uric acid in the urine. And it's kind of a different mechanism, but it actually really decreases the risk of calcium-based stones. The use of it for preventing uric acid stones is a little bit controversial, but that is still something that's commonly kind of done. And for some people who have very, very high serum uric acid levels, it may help with that. More rare things, acetohydroxyamic acid, that's used for some like infection-based stones. It is very poorly tolerated by patients. That's almost never used these days. And then if you have cystine stones, there are some special medications used to treat those as well. But again, not too common in Hawaii. So just a few frequently asked questions, unless Eric, do I have time or should I answer other people's regular questions?
No, go ahead. Yeah, you still have time.
Okay. What is a staghorn stone? So a staghorn stone is named based on its appearance inside the kidney. And what this is typically it's a large stone that for whatever reason, these people tend not to have very many symptoms. they're typically seen with like recurrent urinary tract infections, and they're usually made of like struvite type material, which is like a softer stone, but it definitely gets very big and can grow pretty quickly and can cause very poor kidney function. And oftentimes you'll need that operation through the back to actually get rid of these. Another one you get asked is, if I have stones, will my kids have stones? And stones are more common in people who have a family history, but the reason for that is thought to be more related to kind of the shared diet and hydration practices within the family, rather than like there's some genetic link. Sometimes there is a genetic link, but usually it's the diet and hydration practices are just kind of shared within the family unit. Can stones damage my kidneys? And the answer is yes, they can, but usually only if they're not addressed. So if you get repeated infections, if you have prolonged blockages, you sit on for a while, yes, those things can increase the risk of stones. Sorry, question about, can some medications increase the risk of stones? Yes, there are a few medications that can increase the risk of stones, typically by making the urine more acidic, or kind of they're things that adjust the kidney function. But usually we're able to get around that. In most of those, I actually don't prescribe, but the primary care doctors will, and they probably should talk with you about that if you have a history of stones. Next one, and this is probably the one that, like, if anyone is watching this who's had a stone, you may be familiar with a stent. So the question is, do stents hurt? I get asked that a lot. And this is a stent. So 1/3 of people have no symptoms. 1/3 of people have mild irritation, usually just kind of like some bother when they're urinating, and there are definitely a solid 1/3 of people who hate them. And there are some medications that can help with the stent if you have one. Tamsulosin, also known as Flomax, which I brought up before, that's thought to kind of help relax the ureter, and that may help make it a little bit more tolerable. Some over-the-counter things you can do: ibuprofen if your kidney function's good enough, or acetaminophen, which is just Tylenol. Those things can help as well. Something else you can do, Pyridium or Azo. Azo is actually over the counter, and actually Pyridium's like not covered by insurance here for a lot of for some reason, but AZO is super cheap. You can buy it usually at like any Longs, and that can help as well. Less commonly, we'll use things like oxybutynin or other kind of overactive bladder medications to help with symptoms, but for a few different reasons, I try not to go to those up front. For the question that was asked, are there medications you can take to enlarge the ureter? So tamsulosin or Flomax, there was one American study that was done which suggested that it helped pass stones, and that was the mechanism that they kind of proposed, was that it kind of helped dilate the ureter, or help, like, if you reduce the size of the contraction, if you reduce the frequency of contractions but increase the size, that helps the stone pass. There was a European study that kind of was probably better done, that kind of argued against that. So there's not really a medication necessarily that can increase the size of the ureter, but it is controversial whether Flomax can help you enlarge, in one way or another, help you pass a stone. The things that enlarge the ureter are typically, if you have passed a stone before, you usually kind of dilated out the ureter all the way down. So that does increase the chance of you being able to pass in the future. If you've ever had a stent in place, that does dilate the ureter, and for a lot of people, that actually kind of can help them pass stones in the future as well. Or if you've ever had like ureteroscopy or any of the surgeries we do, oftentimes those will lead to things that will dilate the ureter and can help you pass stones in the future. Another question I get asked a lot is, how is my stent going to be removed? So if you're only going to have your stent like around a week, it will usually have a string coming out the meatus or the shishi hole. Don't pull on the string yourself unless we tell you. And this is usually what it looks like. There's basically this tube coming down the ureter. That's the blue thing. It has a little curl in your bladder, and then the string's coming out the urethra. And when we see you in clinic, we'll usually pull on the string, and the stent comes right along with it. It takes a few seconds. It feels a little uncomfortable, but it definitely won't be the worst thing you ever go through. If the stent's going to be in a little bit longer, common ranges are like 2 to 4, maybe 6 weeks. It will be entirely internal. And in those cases, you kind of have to have a quick procedure called a cystoscopy in the office to remove it. It usually takes about 2 minutes, and we grab it and we just pull it out. How do I decide how long to leave a stent is another question I get asked. It is a lot of factors. It depends on how your ureter looks after surgery. Like, did the stone do a bunch of damage? Did the sheath we have to put up dilate you too much? you have a history of strictures. So strictures are something, it's basically scarring that can happen in the ureter in relation to either a stone or a procedure. If you have that in the past, usually I'm more inclined to leave the stent for a little longer. Did we get all the stone out or not? If you still have stone left, I'll usually leave a stent a little bit longer. If we got it all, then sometimes I don't even leave one. And then are you going to need additional surgery to take more stone out? If the answer is yes, usually you'll have a stent that stays until that next procedure. If the answer is no, then usually it's, somewhere a week to a few weeks. And this is a really big one actually out here at West. We've had a number of patients who kind of have this issue. So what happens if I leave my stent in forever? And this gets back to the fact these stents are temporary. So most of the stents are okay up to 6 months. After this, there's a risk of something called incrustation, or basically growing giant stones around the stent, which this really can happen to any foreign body in your urinary tract you leave for too long. They just tend to start forming these crystals and stones around them. And you really see these massive stones form around the stent. So if you look at like this X-ray, you see that all that like that white, you can see where like the tube is on the right side of the image. And then around that tube, you see all this kind of like a little bit less white stuff up in the kidney near the top, and then also down in the bladder. Those are basically huge stones that form around these things. And that's a very big problem. And oftentimes you're going to have to go to the OR multiple times to get these things removed. And ultimately you may, like this person here probably is going to lose their kidney. The other thing too is that sometimes these can lead to kind of life-threatening infections if they do get colonized with bacteria. So if you have a stent, there needs to be a plan to get it out. Do not just disappear. And then where can some patients like to read on their own? Where can you get more information? In general, for almost anything urology, the Urology Care Foundation is a website run by the American Urologic Association. And under the resources section, there's a ton of just like patient-oriented material that's kind of like written for patients. And it's a really good place to start for anything. In particular, there is, I think, a 13-page patient guide for kidney stones on here. And that it's got some really great information about all the treatments and everything else. So sorry I used almost, and this is the website for them. And then, sorry I used almost all the time, but that's pretty much it.
No, that's great. Thank you, Dr. Sun, for the FAQ. But we do have a question in our chat box. The first question is coming from John Adol Castillo. Can some prescribed drugs taken daily cause stones?
Yeah, there are some in particular, like diabetic. Some of the diabetic drugs will cause you to have increased, or cause your urine to be more acidic. Those can increase the risk of stones. If I'm honest with you, usually your primary care is kind of taking that into consideration. And if they still feel like you need it, we just have to work around that. But yes, there are some medications that can increase your risk of stones.
And John actually has a second question. Is your urologist the one doing needed surgical procedures, or do you need another surgeon?
No, the urologist is typically the surgeon doing the procedures for stones. Rarely we may get the interventional radiologists involved to kind of help us get access to the kidney. Some of us do that, some of us don't. But in general, yes, the urologist is the one doing all the procedures.
I see. How about if, this is a question from me. If someone had kidney stones before, so they went to the ER, and then next thing you know, they realize they're having another stone coming out. If they know it's really kidney stones, do you recommend that they just go to the ER, or can they just, stay home and try to see if they can just have it pass through?
It depends how bad they are. So if they pass stones successfully and the pain's manageable, it's usually reasonable to let your primary know that this is happening, and then also just start hydrating well and just start doing the things you need to do to try to pass it. That's usually what I'd start with. But if it's like the pain's really severe, or you're throwing up a ton and you just can't function, then going to the ER is not a bad idea, because that is the fastest way probably to get the CT scan done to confirm it, and then give you a better idea about, are you going to be able to pass this or not.
I see. All right, any more questions from our viewers? We have a question from George. He said, do you prefer CT versus US to confirm stone or rule it out?
Yeah,
Ultrasound.
Yeah.
Mm-hmm. Yeah. Mm-hmm.
Yeah. So If I'm going to take you to the OR, I like to have a CT because that'll be really accurate. But in general, if it's someone who's like had stones before and we're like, not entirely sure, I'll do an ultrasound usually kind of like as an initial test. And then if there's like hydronephrosis or that swelling in the kidney, or they have like potentially really big stones seen, then I'll usually get the CT. In general, if you're having like an acute problem, like you're having a lot of pain or we think you're passing it, I'll usually just go straight to CT because that kind of answers all the questions. Ultrasound is generally really good for looking for big problems, like if you have a bad blockage or you have a really big stone in the kidney. The problem with ultrasound are you can't really reliably see the ureters, and unless it's a huge stone, the stone measurements on ultrasound are really unreliable. So like we'll have people here with the ultrasound will read a 1 centimeter stone and CT scan shows they have nothing. Or you'll have things where the ultrasound will read they only have like, here and there, and the CT shows that the ultrasound probably missed this huge stone up in the upper pole. So usually I use ultrasound as like a screening. And then if there are concerns or if the symptoms are bad enough, I just get a CT.
See. All right, anyone else? All right, look like that's the end of our Q&A portion. And again, I would like to thank once again our speaker, Dr. Andrew Sun, a urologist here at the Queens Medical Center, West Oahu, and of course to all of you, our virtual audience. And that concludes our Speaking of Health presentation for May. At this time, we'd like to ask all of you to please complete the online poll, which should pop up on your screen momentarily. It is a brief poll, so we will give you a minute. As always, we'd love to hear your feedback and comments. So again, you have a minute, and please make sure you don't log off after you complete your poll. All right, so everyone is done? All right, great. Again, the West Oahu Virtual Speaking of Health series, the third Thursday of each month, same time, 12:30 to 1:30 p.m. Tune in for the next lecture, which will be coming to you on Thursday, June 17th. And our speaker will be our ENT, ear, nose, and throat APRN, Beth Allison, who will be talking about nasal allergies from symptoms to treatment. Again, she'll be talking about nasal allergies from symptoms to treatment. Look out for the announcement, which will include registration information. We hope to see you then, and feel free to share or forward that announcement to your friends, family, colleagues, and anyone you think may be interested. On behalf of our CEO and Senior Vice President, Susan Murray, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queens Medical Center West Ohana, mahalo no lua. Thank you very much for joining us today. Until next time, please take care and always be safe.